we look back, what we studied for the central nervous system and peripheral nervous system. Okay, so I think this is a good way to start. I just wonder, like say, if we are in the college together, and if I see you and if I say, hey, hello, shake hand. So now we have shaking hands. So you know that the hands are being touched, and sometimes we squeeze a little bit for the handshake. So that is where we start here, sensory receptors. So let's say if you are doing handshake with another person, what sort of receptors are being stimulated? Can somebody answer me, please? So
pressure.
Pressure, yeah. So if you have a little gentle squeeze, that is a pressure. And number two, touch, isn't it? Yeah, touch receptor, pressure receptor, being stimulated. And sometimes if your hand is cold or hot, when you are shaking hands, you shake hand with the cold hand. Yeah, so that means thermoreceptor as well. So when we are shaking hands, then at least 3 types of receptors being stimulated. They could be touch receptor, pressure receptor, and thermoreceptor, just from the handshake activity. So this stimulus, which is the meeting each hand, then at least 3 receptors being stimulated. So how can we classify these receptors in different way? So the way we classify touch, temperature, and the pressure, that is depending on the function of the receptor. But on the other hand, if we classify the receptors in different way, these receptors are exteroreceptor, isn't it? So exteroreceptor, which is exposed to the environment. Let's say if there is any pH changes in a patient, let's say a patient has got renal failure, who has a lot of hydrogen ion, being very acidic, and the chemoreceptors inside the body detect these hydrogen ion changes. And what sort of receptor are the chemoreceptors? They are enteroreceptor, isn't it? It is inside, within the body. So now we have 2 types of receptors, at least exteroreceptor, which could be touch, temperature, pressure, or enteroreceptor, which will detect the hydrogen ion changes, carbon dioxide changes, so low calcium, high calcium, and anything. So now, because we are shaking hands and our sensory receptors being stimulated, and these sensory receptors are present in our skin. Yeah, so the nerve from the sensory receptors from the skin being stimulated, and they will carry the sense being touched or being pressed, pressure. They will be conducted as action potential, like electrical signal, along the sensory neuron. This electrical potential is going there along the sensory neuron and going along, and then just go and relay the information in the dorsal root ganglia. And there will be another neuron starting from the dorsal root ganglia, going into the posterior root and the posterior horn of the spinal cord. And there will be another relay here. And we have the interneural, or this information, electrical info, may return to the limb via the interneural and along the motor neural, or that might go cross it and then go up to the brain. Hey, I'm shaking hands with somebody. I have to say hello. That stimulate. Or you just, that person's hand is so cold and you just quickly just pull your hands away from that person. That is your motor neuron. So, and from the anterior horn of the spinal cord, the motor neuron come out, and the and ventral root, and then come out and then go and supply the muscle, and you will respond appropriate. So the combination of sensory neuron and motor neuron, and it is called the periphery nerve. So the nerve we see like radial nerve, ulnar nerve, sciatic nerve, these are the combination of sensory and motor neuron. Of course, a nerve could be both sensory and motor, or a nerve could be just purely motor, or might be purely sensory. So they will not be useful for motor movement. They are purely for the sensation. For example, like our olfactory nerve. Olfactory nerve is in the beginning of the olfactory nerve, start from the nasal epithelium, olfactory receptors, which sense the chemicals, comes into the nose, nasal cavity, and that trigger the stimulus. So now we have the sensory receptor, go along the sensory neuron, go and relay the information in the dorsal root ganglion. Another neuron begin and go into the spinal cord because it is sensory. So it will go from the posterior root and posterior horn of the spinal cord, gray matter. And there will be number 3 neuron, which might go cross to the opposite side and go up along the spinal cord to the brain, or it might just come along with the interneuron and then come back to the, and from the anterior horn, anterior root, and then come back out and then go and act on the fiber along the motor neuron. So let's start with the peripheral receptors. What is a receptor? These are the structures that pick up stimuli. So the touch sensation, the pressure sensation, the temperature sensation, so any stimuli. So these receptors are structures that will pick up the sensory stimuli and that initiate the signal in the sensory axon. So it will go along the sensory neuron. And the receptor could be like just anything, like free nerve ending or well-prepared complete receptor cells. So let's go and look at that. This is our skin, and these are the different types of receptors present in our skin. Look at that. How many? 1, 2, 3, 4, 5, 6, 7. So at least, 7 receptors are present in one particular area of our skin. So they could be acting as a free nerve endings. They could be acting as a Mason's corpuscle, reference endings, hair root plexus, Pacinian corpuscle, cross end bulbs, or Magel's disc. So don't worry about these names, but I want you to remember in one particular pinpoint area, we have this different number of receptors present in our skin. So our textbook try to classify these receptors in a slightly better way. So receptors could be, according to the location, we have exterior receptors, example skin receptors, interior receptors, example internal organs, or proprioceptors, those muscles, tendon, joints, they have very particular receptor. That is what we call proprioceptors. So that depends on their location. Okay, so depending on the stimuli they detect, as we know, like temperature receptor, thermo, pressure receptor, mechano, chemical receptor, chemo, light receptor, photo. So photoreceptors will be present in our eyes so that the outer source came into our eyes as light, and our photoreceptors will pick up the light and interpret, go to the brain and interpret as an image. That is wonderful. And nociceptors. Nociceptor means anything nuisance and pleasant sensation. So this depends on the stimuli they detect, and this depend on where they are. So exteroreceptor could be thermoreceptor, mechanoreceptor, or photoreceptor, or nociceptors, so on and on. So receptors by structures. So that's what we were talking about. The encapsulated receptors, capsulated, non-encapsulated, encapsulated, lamellar corpuscle, bulbous, master spindle, tendon, organs, joint kinetic receptor. So we put these muscle, tendon, and joint receptor into proprioceptors. And for the rest, we have a little look. We have a little look. So this is a page from our textbook. So the classifying the receptors according to their structure, like free nerve endings or modified free nerve endings or hair follicle receptors, and where do they exist, location in the body, and their function. So for example, free nerve endings. Let's look at the free nerve endings receptor. Where do they present? Most of the body tissue, most dense in connective tissue, ligament, tendons, dermis, and the basal layer of epidermis. So they could be like exteroceptors, interoceptors, proprioceptors, nociceptors. So let's, don't dig too far, but at least now we know that our skin we have free nerve endings, which will detect these stimuli. And what about this? Modified free nerve endings. It is a little bit more simple. It is basal layer of the epidermis. It's so not as much as the free nerve endings. Of course, throughout our skin, every part of our skin, because we know being touched, and we will have the free nerve ending receptors. Hair follicle receptors. So it is only present in the hair follicles in and surrounding hair follicles. What do they detect? They act as an exteroceptor and hair deflection. So if you have a good skin, you know that you have a good skin because you have the hair follicle receptors. So that is from the free nerve endings. So we said that encapsulated and proprioceptors. So encapsulated, under the encapsulated, we have tactile or messiness, lamellar or Pacinian, and bulbous corpuscle or rufinous endings. Yes, where are they? They are a little bit interesting, especially messiness receptor, which is tactile. So where do they present? They are present in the hairless skin, nipple, genitalia, external genitalia, fingertips, eyelids. And what do they detect? They detect because they are at the external environment. So they are according to the location, they are the exteroceptors. And structure, they are mechanoreceptors, light, pressure, discriminative touch, vibration, and low frequency. So now we know that, let's say at the tip of our finger, external genitalia, where there is no skin and no hair follicles, no hair, then we know that we have the messiness corpuscle. Proprioceptors, we know proprioceptors. Where are they present? They will be present in the muscles and tendons. They will in the muscle, they will present as muscle spindles, skeletal muscle, particularly of those in extremities. So location, they are proprioceptors, and structure, they are mechanoreceptors, muscle being stretched. Joint kinesthetic, so they will the joint capsule, synovial membrane being touched. So these are the different types of receptor which will detect every changes in our environment. If they are exteroreceptors, if they are interoreceptors, then they will detect any changes from the visceral organs, and proprioceptors will detect the bone and joint and muscles and tendon. That is the muscle spindle receptors, which is a little bit complex to understand, but I just want to remember inside our muscle, we have the muscle spindle. Look at that with the color coded with the purple color. And inside the muscle spindle, we have the intrafusal muscle fibers. And we have the, where is it? Yeah. Spinal nerve endings, look at color with the blue, which just spiral around the intrafusal muscle fiber. And now we know the different type of receptors, and then the neuron will take the stimulus from the receptor along the dorsal, along the sensory neuron, and sensory neuron is nothing more than an axon being covered with the myelin sheath, being covered with the endoneurium, multiple endoneurium packed axon will be covered with the perineurium and then being packed with the epineurium. That is a peripheral nerve. So the stimuli from our receptor will be taken along the axon. Of course, we have multiple axons, so that information will be taken to our central nervous system very quick, and they will take a lot of information from the receptors because we have a lot of receptors present in our skin, and they will be taken along the axon as the action potential. Of course, we have many axons, look at that. And the combination of multiple axons is called the peripheral nerve. And now our sensory will come into our central nervous system, which is the spinal cord, along the dorsal root or sensory root or posterior root, go in, and then our motor will come out from the anterior root or ventral root here. So combination of the dorsal and ventral root combination is called the spinal nerve. And if you look at a little bit more details, like we know that we have two types of sensation. Number one sensation is somatic sensory, and number two sensation is visceral sensory. Somatic sensation means from our body, so like from our hand, touch, temperature, pain, pressure, proprioception. So these are the somatic sensory. And visceral sensory, these are the sensation coming from the visceral organs, like our stomach being stretched because we have eaten a lot of breakfast. So our stomach being stretched. So that stretch sensation will come along the visceral sensory neuron. And then they will go in, they are different color coded. They will go into the posterior root or dorsal root ganglia. There will be relay of the information, and another neuron begins here again, go to the posterior root. And as we remember, the somatic sensory portion inside the dorsal posterior horn of the gray matter of the spinal cord is very posterior, and the neurons for the visceral sensory is a bit more anterior in the posterior root. The same thing like somatic motor neurons will be very anterior and visceral motor is slightly more lateral. Okay, from this area, the motor neurons originate and they will come out from the ventral or anterior root, and then they will go to the somatic motor neurons, so skeletal muscle or visceral motor neurons. So for example, like stomach, intestine, and that sort of stuff. So a nerve, a spinal nerve could be like sensory and motor, but the combination of these roots, divide and march, that is what we call the plexuses, the nerve plexuses. Multiple roots, multiple spinal nerves, we join together, we mix and match, and then we divide again. These happen in cervical or lumbar or sacrum, but these do not happen in thoracic 2 to thoracic 12. Okay, so let's look at the junction or connection of the peripheral nervous system and the central nervous system. Central nervous system is brain and spinal cord, isn't it? Brain and spinal cord. So this is the spinal cord. Therefore, it is the central nervous system. And central nervous system, like the brain and spinal cord, they are covered with the meninges. Meninge has 3 layers. They are outermost dura mater, middle arachnoid mater, and innermost pia mater. Pia mater is very much stuck to the spinal cord substance. It is so difficult to peel off from the spinal cord. And between the layer between the arachnoid and the pia mater, we have the blood vessels. And therefore, this space between the arachnoid and the pia, because it is underneath the arachnoid, and therefore we call this space subarachnoid space. Sub means underneath the arachnoid, subarachnoid space. So in subarachnoid space, we can see the arteries and veins here, and we have the cerebrospinal fluid, which is circulating in the central canal here or in the subarachnoid space. So our cerebrospinal fluid, which is called CSF, is circulating in the central canal and the subarachnoid space, which is just underneath the arachnoid, which is the space between the arachnoid and the pia mater. So therefore, if a patient has got subarachnoid hemorrhage, the bleeding in the subarachnoid space, if we do the lumbar puncture, we can see the blood in the CSF, because that blood will circulate in the subarachnoid space. And the junction of the peripheral nervous system and central nervous system, now you can see the spinal nerve coming in, and then dorsal root. Dorsal root, when it's attached to the spinal cord, it divides into multiple small rootlets and go into the posterior horn of the posterior horn, or where is the dorsal horn, posterior horn of the gray matter, and our motor neuron will come out from the anterior horn, ventral horn of the gray matter, as starting with the multiple rootlets, very, very small, tiny rootlets, and they will join to form the roots, and the combination of the dorsal and ventral root is called the spinal nerve. And we have to say the spinal nerve is very short. Look at that. The dorsal root and ventral root join, that is called spinal nerve, and immediately it divides into posterior or dorsal ramus and anterior or ventral ramus. Dorsal roots fan out into multiple small rootlets form the ventral root. Right. So now this is the spinal nerve, and this is the dorsal ramus, and this is the ventral ramus. So the names are just a little bit, just walking around with the dorsal and ventral, or anterior and posterior. This is what we call root. This is what we call ramus. Dura mater, arachnoid mater, and pia mater. Bang. So now you can see the spinal cord, anterior horn of the gray matter, posterior horn of the gray matter, the central canal where we have the CSF, the three coverings of the brain and spinal cord, which is called spinal meninges, dura mater, arachnoid mater, and pia mater. The cerebrospinal fluid is between the arachnoid and pia mater, so it is underneath the arachnoid, and therefore we call the space subarachnoid space. Look at the dorsal root going in and ventral root coming out. Combination is called spinal nerve. Spinal nerve we divide into posterior or dorsal ramus and anterior or ventral ramus. And we know that these dorsal ramus will go to the muscles of the back. So our erector spinae. So if you're sitting now, then your back muscle will be in action. These muscles and the muscles on the dorsal aspect of your body will be supplied by this dorsal ramus. And this anterior ramus, they will march together, they will divide, and they will become the peripheral nerves. Okay. And now we have the cervical plexus now. How do we get it from these anterior or ventral ramus from the cervical 1, 2, 3, 4, 5? They will march together, they will mix and mesh, and then finally they will divide and split again. And by doing so, we have, when they are merging and splitting, like a motorway junction, that is what we call the plexus, cervical plexus. Okay, cervical plexus, where if we want to explore somebody's cervical plexus, where should we go? We should go to the sternocleidomastoid muscle. So go and find the sternocleidomastoid muscle, and then just behind the sternocleidomastoid and just posterior to the sternocleidomastoid, which is what we call the posterior triangle of the neck, we will find these cervical plexus in the posterior triangle of the neck and posterior to the sternocleidomastoid. Okay, I want you to remember one nerve coming from the cervical plexus, and that nerve is called, I'm waiting.
The phrenic nerve?
Phrenic nerve. Okay. So let's say you and me, we are the surgeons and we are messing around in the somebody's posterior triangle of the neck. And we are a little bit awkward and we are not careful. And now we damage the phrenic nerve. What is going to happen?
They won't be able to breathe because their diaphragm uses
Perfect. Yeah, so this is what's happened here. Okay, so look at the picture. This is the chest X-ray. Yeah, this is the right lungs, and this is the left lungs. So normally, this is the diaphragm, dome of the diaphragm here. This is the dome of the diaphragm here. So normally, which side of the diaphragm is higher? This is right, and this is
right.
left. Yeah, right. Perfect. Why is that?
Because the heart's on the left.
Yeah, heart is from the left end. Liver is on the right, isn't it? Liver is on the right. So liver is on the right and heart is on the left. And therefore, right diaphragm is higher than the left. And now it is opposite. Look at that. Left hemidiaphragm, half of the diaphragm is higher than the right side. Look at that. Yeah. So look at that. Left diaphragm is far higher than the right side. And why is that? So there are many possible causes. So you are going to see this sort of set of scenario when you are doing the clinical, when you are in the clinical environment. Like you might be doing in the radiology, working in the radiology department. You might be working in the ER. You might be on the ward. You might be in the operating theater. You look at that, and one diaphragm is very much higher than the other side. And you have to think, what's going on? Boom. So what are the causes of the raised hemidiaphragm? Yeah. So what are the causes of raised hemidiaphragm? So raised half of the diaphragm, one diaphragm is here, where at least, they might be here, they might be here, I can accept it, but it is much high up here. We cannot accept it. This is a raised hemidiaphragm. And once you see that, you have to click and switch your brain. Possible causes. Number one, so anything like we try to filter out with the surgical filter. So we are, as a clinician, there are too many things we need to remember in our life, and we cannot remember everything, bits and pieces, A, B, C, D, E, F, G. We cannot remember. So we try to group into two groups. So let's say, for example, like if I have 30 students in my class, I will try to classify, hey, boys and girls, or might be tall and short, or might be white, black, colored, or anything. So that's the way, at least I can divide into, let's say, boy and girl. So at least two groups. And some will go, like female will go into the girls group, and males will go into the boys group. And then that's easy to remember. The same thing, like anything in life, you try to make it simple. And if there is any problem, I want you to take this information. If you see any problem, you have to think, what are the causes? And causes could be congenital or acquired. Congenital means someone born with that. Let's say if you see somebody without one eye, you have to think, what's the possibility? The possibility, number one, he might grow up without one eye. That's one possibility. Or number two is like acquired. He just had it. Of course, the younger person you see, like it's more likely to be a congenital problem. Let's say if you see a little baby with only 4 fingers, then that is highly likely to be congenital. They are born with that. Or if you see a 60-year-old patient with only 4 fingers, and that might be traumatic, because trauma is very common. So that's the way, at least you have to split into two. If you see a medical condition, medical problem, I want you to split into two, congenital and acquired. So congenital means they are born with that. That's a bad luck. Or acquire, it happened, something happened to these patients. So the acquired problem could be trauma, infection, cancer or malignancy, or any neurological, any inflammatory, or any idiopathic. Idiopathic means we don't know why this happened. Idiopathic, and no. So yes, we were talking about the raised hemidiaphragm, and we start to think congenital and acquired. Of course, it is congenital. You can ask the patient, why are you born with that? Or were they born with that? It happened in pediatrics because, when the child is delivered, and then if the baby is big, being pulled too much, they damage the cervical plexus and they got phrenic nerve injury. Okay, let's stick to the acquired. So because we are exploring somebody's neck in the posterior triangle, and we didn't appreciate the phrenic nerve. And therefore, because of the surgery, phrenic nerve can got damaged, and because surgery is trauma, and trauma is one of the causes of phrenic nerve injury, phrenic nerve. And infection, look at that infection. Like you guys might not remember the poliomyelitis. Poliomyelitis was such a hell. Like people having problem with polio and many people die. It's just like COVID. Like many people die, many people have disability with polio. Polio virus, it's a viral infection. And polio virus can damage the motor neuron of the phrenic nerve. Hey, this person got hemiparalysis of the diaphragm. Why? Because infection, which is the viral infection to the phrenic nerve. Malignancy, cancer. So if you see one side is raised, the phrenic, you worry about phrenic nerve, and you have to think, look at any malignant lesion somewhere around here in the neck or in the chest. So malignancy, like the cancer cell are wrapping around the phrenic nerve and phrenic nerve damage. And neurological, like multiple sclerosis, nerve injuries, so common to get this multiple sclerosis, which is not uncommon in this northern hemisphere. Or inflammatory disease like sarcoidosis and idiopathic, which we don't know, we cannot find why this happened. So this is the possible causes of phrenic nerve injury. And of course, it might not be just a phrenic nerve, it might be the lungs here, the lung collapse, or the pleural effusion. So these, we have to have a open-minded, we need to be open-minded. But what we are talking about is phrenic nerve injury. If we damage one side, that will be raised hemidiaphragm. So if both phrenic nerve injury, that will be so difficult to breathe for the patient. Why? Because diaphragm is one of the muscle of inspiration. So what is the other muscle of inspiration? These are the intercostal muscles, isn't it? Intercostal muscles, like external intercostal, internal intercostal muscle. These intercostal muscles, they are running like that on the chest, and they make the chest cavity wide. The diaphragm pull the chest cavity down, so the vertical diameter of the thoracic cavity increase with diaphragm contraction. And the external oblique, external intercostal, intercostal, they will pull the chest wall outwards. So that's the way our chest wall. So the hemidiaphragm, like only one side diaphragm damage, they might struggle a little bit, but they might be okay. But both diaphragms damage, then that is a struggle. That is like the patient will be gasping for a breath, because it is so difficult for these patients to take a breath in without the diaphragm, because it is a big muscle which increases the vertical diameter of the thoracic volume. Okay, so now look at that. So the neck being pushed away like that. So this sort of injury, they could happen for something like, like tackled contact sports, for example, like American football. The guy being pushed, each other running away, being pushed, and then go to the ground, and the neck and the shoulder being split away like that, bang. Or sometimes you can see these injury in the motorcyclists. Motorbike accidents are like they can get any injury because they are exposed to the external environment at a high speed. So motorbikes, for me, they are a little bit dangerous, but those people who are good at that. So anyway, so the neck and the shoulder being split like that, and now you are pulling the nerve roots from the spinal cord, which you have seen it already. The small little rootlets attached to the spinal cord. These small little rootlets will get being pulled, and this sort of, whenever you see motorcyclists or like a rough, like heavy contact sports, for example, like American football, if they injure their shoulder or their head or neck, we got to be cautious with this sort of injury. That is where they get the American foot, so brachial plexus injury. And this brachial plexus can be damaged from the root, where the spinal cord and the rootlets junction, or along the nerve, or along the any part of the brachial plexus. We have to expect, and we have to suspect, and we have to check for these patients. And therefore, trauma, we got to be cautious. So now we're talking about the brachial plexus, which is the formation of cervical 5, 6, 7, and thoracic 1 nerve roots. Yeah. So of course, as you know, they are the anterior or ventral rami from the cervical 5, cervical 6, cervical 7, cervical 8, and thoracic 1. Yeah. So all these 5 anterior rami or ventral rami here, we march and join and then form a plexus and finally leave and become the individual muscle. And we studied about the different parts of the brachial plexus. The way we try to remember is Robert Taylor drinks cold beer. Roberts mean roots from the C5, C6, C7, C8, T1. Taylor mean C5 and C6 will combine to form upper trunk. C8 and T1 will form the lower trunk, and C7 on its own will run as the middle trunk. So the roots and the trunk, if we want to find the roots and the trunk, where do we need to go and find? We will have to go and dig around the middle scaling muscle. And now these trunks will divide into anterior and posterior, anterior and posterior, anterior and posterior. So now 3 trunks will give us 6 divisions. If we want to find the divisions, we have to explore around the middle part of the clavicle. Look at that. And then these anterior divisions, all the posterior divisions will combine to form the posterior cord. The upper 2 division will join to form the lateral cord, and the lower trunk anterior division will continue as the medial cord. So why do we call lateral, medial, and posterior? Because it is in relation to the axillary artery. Look at the axillary artery running here. And of course, finally, the lateral cord, medial cord, posterior cords will split and divide again as the peripheral nerve. So here, the multiple nerves coming out from the 3 cords. So when we see this sort of injury, we will be suspecting the brachial plexus injury. And brachial plexus injury could be anywhere from the root injury, or the trunk injury, or the division injury, or the cord injury, or the one and single peripheral nerve injury. So if we suspect brachial plexus injury, we need to suspect these sites of injuries. Right, and if we go a little bit more on the brachial plexus, now we can see the cervical 5 and cervical 6 form the upper trunk. Cervical 7 will continue as middle trunk. Cervical 8 and thoracic 1 will combine as lower trunk. Sometimes, not always, and rarely might be, the cervical 4 might contribute to something. Forget about cervical 4. We will remember as C5 to T1, 5 nerve, spinal nerve roots, anterior or ventral rami combine to form the brachial plexus. And the root trunk division cord and the individual nerve. So this is a nice diagram, and this is also a very nice diagram. And this is the cadaver. So this is the cadaver. So, you know, if you are in the lab, we will have to study with this. And now we can see the C5, 6, 7, 8, T1. Look at that, the way they divide and split, and finally become these spinal nerves. So we need to remember to some extent, you know, at least we will forget that, but we will we need to have a foundation so that for the rest of your career, your education, you at least, you know the mnemonic, but you might not remember in detail, but at least you remember the mnemonics of the branches or individual peripheral nerves coming from the brachial plexus, the last part of the brachial plexus before they become individual nerve is the cord, isn't it? Lateral cord, medial cord, posterior cord. From the lateral cord, the nerve came out as love me Lily, yeah, individual nerve. Love me lateral pectoral, me musculocutaneous, and Lily is for lateral portion of the median nerve. And medial cord is the way we remember you may marry me, Mary. So you ulnar nerve. So at least I want you to remember ulnar nerve comes from the medial cord. So lateral pectoral, medial pectoral. Medial, the portion of the median nerve. So median nerve originate from the medial cord and lateral cord merged together. Medial cutaneous nerve for arm, medial cutaneous nerve for forearm. Posterior cord as a star, subscapular nerve. So upper and lower subscapular nerve, T thoracodorsal nerve, and axillary and radial. So at least I want you to remember axillary and radial arise from the posterior cord. Okay. So now these are the individual nerve. You can see the axillary nerve winding around the neck of the humerus. And this nerve is very prone to injury for somebody with the dislocated shoulder. So dislocated shoulder patient, you have to assess the axillary nerve function. So axillary nerve is the motor and sensory mixed nerve. It is not pure motor, it is not pure sensory, it is a mixed nerve, which is combination of motor and sensory nerve. So motor function of the axillary nerve is for the muscle here, what is the muscle around the shoulder, which gives the contour of the shoulder?
Deltoid.
Deltoid. So axillary nerve will supply the deltoid muscle. Perfect. And the sensory portion of the axillary nerve, where are you going to check?
Is it the anterior deltoid?
Yeah, no, the skin over the deltoid, so which we usually call regimental patch area. So the skin over the deltoid will be supplied by the axillary nerve. The deltoid muscle will be supplied by the motor function of the axillary nerve. So if someone somebody dislocated their shoulder. Shoulder dislocation is very common. Like if you stay in the health environment, like whatever you do, like you are going to see the multiple dislocated shoulders in your life. Like if you walk in the radiology department or emergency room or in the orthopedics department, this shoulder dislocation, because shoulder joint is, as you remember, it's like the glenoid is a little socket, and the humeral head is pretty big. Therefore, our shoulder is very much mobile. It is very unstable. So there is a balance between stability and the movement, isn't it? Because shoulder is like you can do everything you like. So the shoulder joint is very mobile, which means it suffers in a way of the stability. So if you see a shoulder dislocation, you need to check the axillary nerve. Look at the relationship. That if the shoulder from humeral head come out, it will damage this nerve. It's highly likely. So therefore, you have to check hey, can you feel it here on the deltoid area skin? No. Hey, can you use after the reduction? Of course, before you can put it back in, the patient will not be able to move their deltoid. But even then, if you are careful, you can assess the deltoid muscle contraction. If they do not have it, you have to check and you have to document that this patient's axillary nerve injury is secondary to the dislocation. You haven't done anything yet. You haven't touched the patient. You haven't reduced the shoulder. So before the reduction of the joint, you have to check the nerve. Otherwise, after you put it back in, and you don't know whether you damage it or the injury damaged the nerve. Okay, look at this here. Look at this here. Look at the radial nerve. Yeah, the radial nerve is going along here, and then it goes posterior to the humerus, near the middle third, of the humerus, and then this medial structure, radial nerve, become lateral structure after looping around the posterior aspect of the humerus. Now you see this injury. So what is the usual, the mechanism of injury in this? So usually a young guy, yeah, so a little bit muscular. What are they doing? They are arm wrestling. So they arm wrestling each other. And then, yes, because they are strong and because the strength, the bone or the muscle cannot take anymore, and the bone has to give way. So that is pretty common, like, of course, there might be like history of fall and the injury, but like arm wrestling is not an uncommon mechanism of injury. And they break their humerus, spiral injury. Arm wrestling, spiral injury of the junction of the humerus. Look at the bony spike here. Look at the bony spike here. And the break is here. Look at the break is here. And if you think about our previous diagram, hey, radial nerve is just there. So radial nerve also has sensory and motor function, like the same like axillary nerve. So now the patient came in with the broken arm. The friends, they are messing around, arm wrestling, alcohol, having fun, click, and then finally, bang, they crack, they hear it, and then they came in with the previous x-ray I show you, and they cannot move their hand at all. So what's happened is their wrist is dropped like that. That is what they call wrist drop. So they cannot cock up their wrist anymore because the motor function of the radial nerve is for the extensor muscles of the forearm. So almost all extensor muscle of the forearm, which does this job, is supplied by the radial nerve motor. So now they damage the motor function of the radial nerve, and sensation of the radial nerve. Where do we check? Here, look at that. The radial nerve here, radial nerve here, and then radial nerve here. Look at that. So the best place to check is on your dorsum of the hand, between the thumb and the index finger, this area. That is what we call the first web space. So between the thumb on the dorsum aspect of the hand, between the thumb and the index finger, here, this area, you touch it. He cannot feel anything. And then you ask the patient to cock up your wrist, cock up your wrist. He cannot do that. You know that he has damaged his radial nerve injury, because you know the anatomy of the radial nerve, which is looping around just posterior to the humerus from medial to lateral. It is just looping around, starting from here, and then it is spiraling around and then going here. And now the bone spike is pinching on this radial nerve. Had it already. Hey, so that is the injury that is the nerve injury from the fracture, not because of your medical intervention, and you have to document it. Otherwise, when the law comes, we don't know where we start. Okay, so now what we need to do is we have to ORIF, like plate the humerus, plate and screw. And when we do that, we will explore the radial nerve. We need to explore it. We need to know where it is. Is it being tethered by the bony spike, or it is just like being bruised? We don't know. So we will go and explore it. Look at that. That is the posterior aspect of our humerus. Look at that. This is the elbow here, and this is the upper, this is the shoulder. We are making a big cut along the back of our arm, and we are trying to explore the nerve here. Look at that. The first thing you do is you have to go and fish out the nerve before you do any plate or screw. You have to find where the nerve is. It might be 30 minutes or 2-3 hours. Doesn't matter. You have to go and find and fish out the radial nerve, which might be bruised as well, and you identify it. Only after that, you put a plate on the humerus bone and you put the nerve on the plate. You do not want to press the radial nerve in between the bone and the plate and screw. So now you are in control. You just explore it. You go and fish out the nerve here, and you put the plate on the bone, and you leave the nerve on top of the plate. So that is the proximity between the radial nerve and the humerus. So don't forget, if you see this injury, you suspect that another injury, because injuries comes mainly because of the trauma, and trauma is uncontrolled. And if one can damage this, they can damage that as well. Right, lumbar plexus. Lumbar plexus, they are formed by the anterior rami of the lumbar 1, lumbar 2, lumbar 3, lumbar 4. If you want to explore as a surgeon, you need to dig around the psoas major muscle. And the main branches of the lumbar plexus are femoral and obturator nerve. So look at the lumbar plexus from the lumbar 1, lumbar 2, lumbar 3, lumbar 4, lumbar 5. No, lumbar 5 might be sometimes, but usually 1 to 4 without 5. And you can see they are around the psoas muscle. And look at that, the obturator nerve, which is coming out from the obturator foramen and going to the medial aspect of the upper thigh. You can see that. And look at our femoral nerve. Once it comes into the thigh, and then they branch into multiple branches, and one of the branches go along as a saphenous nerve on the medial aspect of our leg, go down to the medial malleolus. Look at, guys, it is wonderful. It is a very long nerve as well. So if we have like a sensation on the medial aspect of our leg, thigh and leg, yeah, it is the femoral nerve. Look at the femoral nerve here. Only the little patch here is supplied by the obturator nerve, which is coming out from the obturator foramen, anterior portion of the thigh, medial aspect of the knee, and medial aspect of the leg. Of course, femoral nerve is originating from the lumbar 2, 3, 4. Yes. So if we damage the lumbar 2 nerve root, that means femoral nerve in total might still be intact, because lumbar 2 and lumbar 3 portion will still work. Of course, lumbar 2 might not work. The sacral plexus is lumbar 4 to S4, anterior rami. They supply the buttock, lower limb, and pelvis. And the main branch from the sacral plexus is sciatic nerve. Look at the nerve here from the lumbar 4 to sacral 4, or here, look at that here. This is the posterior rami. We don't use it. We use only anterior rami for the nerve plexuses. We'll leave it alone for the posterior ribs. Let them supply the posterior part of our body. And we will use only the anterior ramus for the nerve plexus. Look at that, all the anterior ramus we join to form the sacral plexus, and one of the biggest nerve is sciatic nerve. Look at that sciatic nerve, which is the combination of common peroneal and tibial nerve. So look at that sciatic nerve coming out from the sacrum and then divides into two common peroneal, which loops around the neck of the fibula, and another tibia goes straight down into the leg. Okay, so let's take a break. We'll take about 10 minutes break. So we will meet 11:15. So we were talking about sciatic nerve. So all the nerve plexuses, cervical plexus, C1 to C5, brachial plexus, C5 to T1, lumbar plexus, L1 to L4 with or without L5, and sacral plexus, L4 to S4. And these are the nerve plexuses we were talking about. And now we will talk a little bit about the dermatomes. So dermatomes, what is a dermatome? Dermatome, the area of the skin, so that particular area of the skin supplied by innervated by the cutaneous, so sensory branch of the one and single spinal nerve. So the spinal nerve, as you know, we have the sensory portion and motor portion, and that individual spinal nerve root, let's say cervical 2, cervical 3, or just particular portion of the spinal nerve will go and take sensation from that particular area of the skin. So it is different from the peripheral nerve, because as we saw, the peripheral nerves are made of combination of multiple spinal nerve roots, isn't it? Because they have been through the nerve plexuses. So for example, like, you know, if we look at the radial nerve or axillary nerve, radial nerve is a combination of cervical 5, cervical 6, cervical 7, cervical 8, thoracic 1, and axillary nerve is cervical 5, cervical 6. So they are mixed and matched already. So as we said, you know, the axillary nerve will take sensation from the muscles over the deltoid, which we call regimental badge area. And that could be either C5 or C6. So if we damage C5, we might get damage to this area. If we damage C6, we might get damage to this area. So we don't know. So that is like different from the individual nerve, peripheral nerve. This dermatome is that particular area of the skin supplied by the particular spinal nerve. So for us, on the shoulder deltoid is C6, C5. So C5 is for the shoulder deltoid region. So that is important, because if we have loss of sensation in regimental badge area over the deltoid, we can still have the movement of the deltoid. It is because C6 motor is still intact. So we need to clarify, is it if somebody who cannot feel or who cannot move, we have to check whether it is because of the dermatome, spinal nerve root injury, or because of the whole area of the skin, which is the peripheral nerve injury. So we have to differentiate, and therefore this dermatome pattern became important. So dermatome is the particular area of the skin supplied by the particular cutaneous branch from the single spinal nerve, single, one and only spinal nerve. The skin patch area innervated by one spinal nerve only. So all the spinal nerve roots except C1 will give dermatomes. Of course, there will be overlap on our body. And this is our dermatome. So dermatome, if you look at that C5, let's start with the C5, which is the easiest to remember. C5 gives sensation, dermatome for the deltoid shoulder. So you always start with your deltoid region. You point your shoulder like that, and deltoid C5. And above the deltoid, along the neck, from the base of the neck up to the neck is C432. So it is a good point to remember C5. And C6 is our thumb. So if you touch the finger, thumb, if they can feel it, C6 is intact. Middle finger, that is C7. Little finger, C8. Medial aspect of the forearm, T1. Medial aspect of the arm, here look at T2. And you go, and nipple line is thoracic 4. So that is another demarcation line to remember. Nipple line is thoracic 4. So anything above the nipple line will be thoracic 1, thoracic 2, thoracic 3. And anything below the nipple line will be thoracic 4 and below. And Ziphi-Stanner, the Ziphi-Stanner, it is thoracic 8. And our abdomen, umbilicus region is thoracic 10, and our pubic symphysis is thoracic 12. So that is the dermatome, which is different from the peripheral nerve. So, of course, we have to check the individual spinal nerve root sensory. We can check it via the dermatomal region, or we have to check the peripheral nerve, which is the combination of multiple spinal nerve roots. We will check that individual peripheral nerve. So we are now checking the individual spinal nerve roots. C5 is the shoulder, thumb is C6, middle finger is C7, little finger is C8, medial aspect of the forearm, T1, medial aspect of the arm, T2, and nipple line, T4, xiphisternum, T8, umbilicus region, T10. So above the umbilicus, that will be T9, T8, T7, below the umbilicus, T10, 11, 12, and pubic symphysis is T12. And the same thing goes into our leg in our groin. So in our groin is lumbar 1, medial aspect of the knee. Look at that, lumbar 4, medial aspect of the knee is L3. Medial malleolus here is lumbar 4. Our big toe is lumbar 5. Little dorsum aspect of the lateral foot is S1. And our perineal region is, and buttock and perineal region is sacrum 1, 2, 3, 4, 5. Look at that, sacrum 1, 2, 3, 4, 5. So that is the dermatomal pattern. And let's go to the olfactory nerve, cranial nerve, which is the peripheral nerve, which is directly coming from the brain or the brainstem. Yeah. So olfactory nerve is first cranial nerve. We have 12 cranial nerves, and olfactory nerve is purely sensory. Olfactory nerve does not move anything. Olfactory nerve is only for the sensation, which smell. So that is not a regular sensation. Regular sensation means touch, temperature, pressure. That is the normal simple sensation. And special sensation like smell is special sense, and special sense is carried by the olfactory nerve. It transmits the sense of smell from the nasal cavity. In the nasal cavity, there are nasal receptors, sensory receptors for the smell, and these will pick up and will transmit along the first cranial nerve, which is the olfactory nerve, and it will go directly to the brain without crossing the thalamus, because we said, you know, all the sensation coming into our body, we have to go through the thalamus. Thalamus is acting as a switchboard. Anything from outside, we have to come through the switchboard, which is the thalamus. But hey, no, this olfactory nerve is too close to the brain. It will go directly to the brain. So olfactory or first cranial nerve is special sensory, and it is for the smell, and it goes directly to the brain without going through the thalamus. Olfactory and second cranial nerve is optic nerve. Optic, I believe everyone knows optic nerve. It is for the vision, eye. Again, vision is not a normal sensation. It is not just touch. It is not just pressure. It is not just temperature. It is very special because you are seeing many different colors in your eyes every day. It is so special. It is special sense. It is a special sensory nerve, optic nerve. It takes the retina, like I hope you remember rods and cones in the retina of the eye. These stimulus, the photostimulus, the light stimulus will shine on the photoreceptors, rods and cones, and then that start to generate the action potential, which will traverse along the optic nerve and will go to the occiput. And that will create a lot of things. You know, if you see something, you are seeing multiple colors in a meaningful way. And at the same time, this occipital lobe is going to stimulate many other parts of your brain, isn't it? You might feel sad, you might feel happy, you might, because you see something, you remember something. So it is so complex. This olfactory nerve, optic nerve, cranial nerve, is taking all the light and action potential from the retina to the occipital lobe. Second cranial nerve. Look at this. This is our eye. This is the right eye. This is the nose. Look at the nose here. And this is the right eye. We have taken away everything. And this is the right eye. This is the pupil. Look at the pupil here. So our eyes have 6 external ocular muscles. External ocular muscle means these muscles are outside of the eyeball, and this external ocular muscle moves the eyeballs. So we have 6 extraocular muscles. Look at the muscles here. Hey, above the eyeball, we call it superior rectus. Below the eyeball, we call it inferior rectus. Lateral aspect of the eyeball, we call lateral rectus. Medial aspect of the eyeball, medial rectus. And now we have 2 obliques. Here, look at it. Superior oblique and inferior oblique. So our eyeballs have 6 external ocular muscles. What do I mean by external ocular muscle? External ocular muscles mean outside of the eyeball. They are responsible for the movement of the eyes, and there are 6 external ocular muscles. They are one on above, which is called superior rectus muscle, one on the below, inferior rectus muscle. Why do you call rectus muscle? Because it is very straight. Superior rectus, inferior rectus. On the lateral side, we have lateral rectus, and on the medial side, we have medial rectus, and we have superior oblique. Look at that. Why do we call oblique? It comes here, it hook with the bony notch, and then it come back here. The same thing like inferior oblique is going to hook something, and then it will come down to the eyeball. So let's say if our superior rectus muscle contract, we will be looking upwards. If our inferior rectus muscle contract, we will be looking downwards. If the lateral rectus muscle contracting, we'll be looking side, lateral side. If the medial rectus muscle is contracting, we will be looking medial side. So superior oblique muscle, it is oblique. So superior one, because it is oblique, when it is hooked around. So superior rectus contract, the eye will not go upwards, go to downwards. And inferior rectus, the same thing, it will not go up, go downwards, it will go upwards. So because they are oblique. So anyway, we have 6 external ocular muscles in each eye. The way we try to remember is lateral rectus, LR, lateral rectus, is supplied by the 6th cranial nerve. Superior oblique here, superior oblique, SO, for 4th cranial nerve. So trochlea, abduction, LR6, SO4. The rest, all the rest, like rest of the muscle other than superior oblique and lateral, like so superior rectus, inferior rectus, medial rectus, and inferior oblique, they are supplied by the 3rd cranial nerve. So the good way to remember the nerve supply for the extraocular muscle is LR6, SO4, rest 3. Yeah. So LR6, SO4, rest 3. Why do I say that? Because I'm going to talk about the 3rd cranial nerve. Yeah. So I'm going to talk about the 3rd cranial nerve. 3rd cranial nerve is the oculomotor nerve. Hey, the name is so simple. Oculo, eye, motor, movement, eye movement nerve, third cranial nerve. It is a motor nerve. There is no sensory. Visual tracking, of course, if you want to look right side, you use the muscles going to the right and LR6SO4 rest3. If you want to move your eyes upwards, downwards, wherever you move your eyes, then you are using the 6 muscles of the eyes and you are using LR6SO4 rest3. And these 3 nerves supply the 6 external ocular muscles. And the way people try to constrict and dilate. So along the oculomotor nerve, there is a parasympathetic nerve fibers follow with the third cranial nerve, and then it will dilate or constrict the pupil according to the light entering into the eye. And number 3 function of the oculomotor nerve is raise the eyelids. Eyelid muscle is called levator palpebrae superioris. Levator palpebrae superioris. Levator means elevate, palpebral fissure superioris, lifting the eyelids upwards. So when you are opening your eyes, you are using your oculomotor nerve to raise the eyelids. Yeah. So that is the third cranial nerve. Fourth cranial nerve is simple, LR6, lateral rectus trochlear nerve. It is pure motor. It is for the movement of the eye, which is it, lateral rectus muscle, trochlear nerve. Fifth cranial nerve, hey, it is the very, very big cranial nerve. So it is going to divide into 3, frontal, maxillary, and mandibular. Of course, it is 3, it is big, therefore it is a mixed nerve. It is both motor and sensory. So motor function of the trigeminal nerve is muscle of mastication. So let's say if you are eating something for lunch, I want you to remember the 5th cranial nerve. Whenever you eat, you have to say thank you to your 5th cranial nerve. Because of it, you are able to chew the food. It is for the muscles of mastication. And it is also for the touch sensation of the face. So if you touch your forehead, if you touch your cheek, if you touch your face, facial sensation, touch, temperature, pain, it is coming from the 5th cranial nerve. 6th cranial nerve is simple because you know the LR6, lateral rectus, 6th cranial nerve. So the 6th cranial nerve is motor nerve, movement of the eye, lateral rectus. SO4, superior oblique abducens nerve, trochlear nerve, which is the 4th cranial nerve. Rest of the eyeball movement muscle is 3rd cranial nerve, oculomotor nerve. Facial nerve, hey, we need to love our facial nerve. Without facial nerve, we cannot do any facial expression. That will be a disaster. Yeah, if we cannot do any facial expression, that will be a problem. So facial nerve is a mixed motor and sensory nerve. For the motor, it is for the muscle of facial expression. You can smile, you can cry, you can laugh, you can blow your cheek because of the facial nerve, movement of the muscle of facial expression. And sensory, it has got 2 sensory functions, somatic sensory and spatial sensory. Spatial sensory, it takes the taste from the anterior 2/3 of the tongue. So if you put a little bit of sugar at the tip of your tongue, that sweetness will be taken by the facial nerve because you are using the anterior 2/3 of the tongue, the papilla, and therefore it is the facial nerve. Somatic sensory is pain and touch from the ear. So ear sensation like touch, temperature, touch, pain, that is taken from the facial nerve. So facial nerve doesn't take any sensation from the face. It takes sensation from the ear. The facial sensation is fifth cranial nerve, which is the trigeminal nerve. Facial nerve is the movement of the muscle of facial expression. Eighth cranial nerve is vestibulocochlear nerve. The name tells vestibular component and cochlear component. It is purely sensory nerve. Eighth cranial nerve doesn't move anything. It is just a pure cranial nerve, sensory nerve. For the vestibular portion, is for balance. And cochlear portion is for sensation of hearing. Again, like sensation is very, very interesting because if we talk and there will be vibrations in the air and that vibration come into our ear, that moves the eardrum and then just middle ear, stimulate the middle ear, and then inner ear, we take this cochlear portion of the eighth cranial nerve, we take the sensation and interpret in our brain as a language. It is so interesting, you know, it is something very difficult to understand. Not even that, if you hear something, a lot of emotion can come in your mind as well. You might get like, you know, remember the song which you had a good fan, or where you're not having a good time and you hear that song and all the memories come back. That stimulate, this little song stimulate in your ear, and then that will go to the brain and memory and all things mix up. So whatever it is, eighth cranial nerve has got two portions, vestibular and cochlear, vestibular for balance and cochlear for hearing. Okay, so ninth cranial nerve is also called glossopharyngeal nerve. Glosso means tongue, pharyngeal means pharynx. You remember nasopharynx, oropharynx, and laryngopharynx. So pharynx means throat, isn't it? So glossopharyngeal nerve is a mixed sensory and motor nerve. Spatial sensory and somatic sensory. Motor is for swallowing because throat is for swallowing of food. So motor is easy. Spatial sense and somatic sense. Spatial sensation is taken from the posterior 1/3 of the tongue sensation, taste sensation. So now if we put a small piece of sugar on our tongue, anterior 1/3 of the tongue, that taste sensation, sweetness, will be taken by the facial nerve. If we put small piece of sugar in the posterior 1/3 of the tongue, that taste will be taken by the glossopharyngeal nerve, which is the ninth cranial nerve, because anterior to that is facial, posterior 1/3 is glossopharyngeal sensation, spatial taste sensation. And of course, when we have tonsillitis, when we have ulcer on the back of our tongue, the pain, touch, somatic sensory will be taken by the glossopharyngeal nerve. 10th cranial nerve is mixed motor and sensory. This guy, vagus, is wandering around, is going all over the body, yeah? So coming out from the brain and go into the heart, go into the lungs, go into the gastrointestinal tract. This guy is wandering around. And it goes to the glands as well. This is vagus. Vagus is wandering around all our body. Accessory nerve is only motor nerve. You remember small little rootlets coming from the lower part of the brainstem and upper part of the spinal cord. They all join and they all go back into the cranium and come out back again. It is only for the motor, and it is movement of the trapezius and sternocleidomastoid. Sternocleidomastoid means you are using sternocleidomastoid to bend your neck, and trapezius is for shark. So hey, I don't know. That I don't know means you are using your trapezius The trapezius is driven by the accessory nerve, which is also called spinal accessory nerve, which is the 11th cranial nerve. 12th cranial nerve is hypoglossal nerve, pushing the tongue out. Hey, show me your tongue. Yeah, look at that. This is my tongue. Your tongue coming out. Movement of the tongue. You twist your tongue. You fold your tongue. So whenever you move your tongue, you are using your hypoglossal nerve. So that is the 12th cranial nerve. And of course, you know, this just a reminder in very short. This is our brain, and spinal cord makes the central nervous system. The brain, portion of the brains are cerebrum, cerebellum. Inside, around this area, which is called diencephalon, which is made of thalamus, hypothalamus, epithalamus. And now we have our brainstem, which is colored with the green color, which is called midbrain, pons, medulla oblongata. That is brainstem. And yellow means the spinal cord. So where is the junction of the brain and spinal cord? It is here. So where is the foramen magnum, which will be here? Okay. And the brain, portion of the brain, this is now a little bit more detail. Sulcus and gyrus. Sulcus means fissure, deep fissure. Sulcus, you can see in the middle part of the brain, which is called central sulcus. Anything in front of the central sulcus is called the frontal lobe, and anything posterior to the central sulcus is called parietal lobe. And here we will have the occipital lobe, and this is the temporal lobe of the brain. So frontal lobe, parietal lobe, occipital lobe, temporal lobe of the cerebrum, and this is the cerebellum, and this is the brainstem. Look at that. This is the central sulcus. Anything in front of the central sulcus is called frontal lobe. And here, parietal lobe is posterior to the central sulcus. And here is another sulcus, which posterior to it is occipital lobe. You can see the temporal lobe here on the temporal region, and this is the cerebellum. And the brain, human brain, is split into two with the big, deep longitudinal fissure, and we call this right cerebral hemisphere, and this is called left cerebral hemisphere. And these two hemispheres are connected to each other by the corpus callosum, and underneath the corpus callosum, we have the lateral ventricle. We have two lateral ventricles, one on the right hemisphere and one on the left hemisphere, and we have the third ventricle, one and only third ventricle, and we have one and only fourth ventricle. Look at that. The central sulcus here, anterior to the portion of the central sulcus, anterior to the central sulcus is called primary motor cortex. Look at that, primary motor cortex. Posterior, immediately posterior to the central sulcus is called primary sensory cortex. So all the motor movement neurons originate in the motor cortex. All the sensory neurons originate in the postcentral sulcus as gyrus. And this is the premotor cortex. This is a very much limbic association area, and occipital lobe. So then temporal lobe here. And this is the corpus callosum. This is the corpus callosum. This is the lateral ventricle. Here we call it thalamus, epithalamus. Thalamus, epithalamus. So thalamus, epithalamus, posterior commissure, pineal gland, these are called diencephalon. This is the brainstem. If you split half the cerebellum, you can see the cauliflower-shaped structure. If you look at the motor cortex and sensory cortex, the area of representation for different part of the body, this is the representation. Our face has a big representation in the motor cortex, and therefore we can do a lot with our face. We can smile, we can cry, we can just dance, we can just close our eye, we can open our eyes, and we can do everything. And look at that, the area of the hand, which is quite small as the part of the body, highly represent the motor cortex. Therefore, we are so able to move different parts of our hand to use it. And on the opposite, our foot and legs, their representation is pretty small. The same thing, similar but not identical for the sensory cortex. Look at that. Sensory cortex representation for the hand is pretty big. Therefore, our hand has got a lot of sensory receptors, which will go to the brain, and they will represent a big portion of the sensory cortex. And internal capsule, these are the lateral ventricle, third ventricle, all the motor neurons from the motor cortex will come across, and then here, very tiny narrow area. This area of the brain is called internal capsule. Of course, this is the coronal section of the brain. This is the right hemisphere. This is the left hemisphere. Right lateral ventricle, left lateral ventricle, and you can see the basal ganglia, which is made of caudate, putamen, and glottis pallidus nuclei. Nuclei means a condensation of motor neurons. Yeah, so look at that. All the muscle fibers from the motor cortex, they were all marched together, which is here. This looks like a radiation that is called coronal radiator, which keeps coming down in the narrow little lane. That is what we call internal capsule. And then finally at the brainstem level, 80% of the fibers will cross, 20% will continue on its own. The same thing from the right and the left. Look at that. Look at this diagram. This is the motor tracks, coming from the brain, all the motor neurons running down here along the midbrain pons and medulla oblongata. And in the medulla region, 80% will cross, 20% will continue. And therefore, we said right side of the body is controlled by the left, and left side of the body is controlled by the right brain. That is the spinal tract coming down from the cortex of the brain down to the spinal cord. We call it corticospinal tract. And we will have sensory fibers going from the periphery along the spinal cord to the brain. We will call that spinal cortical tract. So now you remember corticospinal tract. What does it mean? From the brain cortex along the spinal cord, or spinal cortical tract from the upward, going from the spine, going up to the brain. And finally, this is the spinal cord, and this is the spinal nerve, and this is the dorsal root. Sensation could be 2, somatic sensory or visceral sensory. Motor could be 2, visceral sensory or somatic, visceral motor or somatic motor. And I want you to appreciate those little areas of the motor neuron, which is located in the spinal cord. This is for somatic sensory. This is for visceral sensory, visceral motor, and somatic motor. Right. That comes to the end of the, just trying to wrap up all the central and peripheral nervous system. So what I would do later today, I will send you some homeworks about the little bit more combine things about this nervous system. Has anyone got any question?
Swain, put in this goddamn time.